I always say the most important diagnosis is clinical. If those clinical pieces don't fit, it doesn't matter what the imaging looks like. And the way we diagnose it is, we started, about 20 years ago, an NPH clinic because interestingly, as a neurosurgeon, I saw a lot of people getting shunts that it was the wrong diagnosis. They were undergoing brain surgery because of these symptoms, and there really was no objective data.
Hi, everybody. Welcome back to the GNI Podcast. My name is Alec Veznedaroglu, and I am the creative director here at Global Neurosciences Institute. I'll be hosting today's podcast where we'll be interviewing Dr. Erol Veznedaroglu, who is the president and CEO of Global Neurosciences Institute. He is also a vascular neurosurgeon and specializes in things like normal pressure hydrocephalus. And that's the topic of today's podcast, as probably a lot of people have seen in the news. Billy Joel was recently diagnosed with that. And it's kind of a complex, name. It's not in layman's terms like I have heart disease or it's relating to the brain. There's a lot of different things that exist and they're very complicated. So we're grateful to have you here today to be able to talk about it.
Sure. Normal pressure hydrocephalus is something that over a very long period of time in the neurology and certainly the neurosurgery fields has gone through a bunch of different names. The understanding of it, we knew it fit into what's called hydrocephalus family, but had very specific characteristics to it. And many people probably heard the term of hydrocephalus or water on the brain with babies. And essentially what that is the ventricular space in the brain where the cerebrospinal fluid is produced balloons up. And it's literally a cavity filled with fluid. And we normally see it where it's hydrocephalus and the pressure in that cavity can get high. And what ends up happening are people have cognitive problems and in acute settings like ruptured aneurysms, head trauma, the patients become lethargic and can quickly go into a coma. It's a life-threatening condition. We see it often in babies where they're born with it for various reasons. But normal pressure hydrocephalus is a very separate entity, and it's usually in the older population. We see it anywhere from 60 to 80, where it becomes clinically prevalent. And there's three symptoms. There's a triad. First is usually the gait. People start shuffling with their gait. They start having balance difficulties. They fall. The second one is cognitive. Memory loss, personality changes, almost comes off as a dementia. And then urinary incontinence. Patients have difficult time holding their bladder, both men and women. So the problem with the diagnosis and the confusion becomes in that age, all three of those things are normal, right? As we get older, our balance, we have bad backs, we have bad knees. And then the cognitive is unfortunately just part of normal aging where we start to lose our memory. We're not as sharp as we were. Sometimes personality changes. And then the urinary continence as well. Men and women start to experience that. So that is often, people don't normally think this is something in the beginning stages as something wrong. The other thing that it's commonly misdiagnosed on and I've seen many times in my clinic, Alzheimer's, Parkinson's, different types of dementias. And the reason it's so important is this is a very treatable disease.
So the patient or the person that's going through this, are they typically the ones that seek help, or is it people in their lives that say, hey, in this case, maybe, Billy Joel's wife saying, or his team, something's not quite right. We don't really notice him the same, like you said, with his gait or obviously with the incontinence, he would have to experience that himself. So do you often see that patients seek help for this themselves, or is it somebody saying, hey, I'm really concerned about my, mother, father, et cetera?
No, it's a great question. And it's a combination of both. But interestingly, it's usually the spouse or loved ones that notice it more. And it's not like Alzheimer's and other types of dementias and even some of the forms of Parkinson's. Some patients are in denial about it, even though it's very obvious. The patients usually acknowledge it, and it's very common where, again, a spouse, a loved one, a partner will say, hey, you're falling a lot, or, you're getting up a lot in the middle of the night to go to the bathroom. I notice you've been having some accidents. That's never happened before. But the big one is the personality change, where it is forgetting things over, a several month period of time, where it becomes more acute and more obvious.
So is this typically seen by neurologists first? Like, is there, there's a difference between, and correct me if I'm wrong, but with neurosurgery and neurology. So you guys at Global Neurosciences, work together in tandem, which is great. But do you often see that patients get referred to neurologists and maybe they don't know how to treat the specific condition, whereas a neurosurgeon will be able to spot this a little bit more quickly? Is the diagnosis easily spotted, I guess is a better question to phrase it as?
Yeah, so it's interesting because it becomes obvious once. That's why patients are like, "Oh my God, we've been followed for this and that." And when you look at the signs and symptoms in patients that truly have this, it does become fairly obvious. Neurologists certainly see a lot of this because coming with the first issue of cognitive decline, things like that. But urologists see these patients, family medicine, internal medicine. And a lot of times spine and orthopedic, with other types of hip issues, knee issues, bad backs. And as neurosurgeons, we see that frequently where it will come to light where you start seeing the way someone's walking, their films don't look that bad, and then you start putting these things together. But the neurosurgeons do the treatment. So the neurosurgeons are the ones that ultimately do the treatment for NPH.
So when somebody comes in and maybe they don't suspect NPH, how do you rule out any other, neurologic conditions like a stroke or anything else that it could be? Or is this pretty prominent, those three symptoms that you listed? You typically look for those, or do you do, a CAT scan or a scan of the brain of some sort?
Yeah, so there's two ways that I see patients and most neurosurgeons see patients with NPH. One is radiographic, where they get a CAT scan and MRI which is usually the starting point if someone's coming with a complaint of memory loss or cognitive decline. And the ventricles, that fluid-filled space is big. The problem is this is not a radiographic diagnosis because anybody over the age of 50 is going to start to have enlarged ventricles. It's just a normal process of the aging brain. The other is the clinical symptoms. And again, it's not always obvious. And it's not, most patients don't right off the bat have all three of these. I think in my experience, what I see the most of is usually it starts off with the gait, which progressively gets worse, then the urinary incontinence, and then the cognitive and the memory issues. So it depends what time the patient is diagnosed. And if it's strictly memory and things like that, you have to rule other things out, like Alzheimer's, like other forms of dementia. And if it's, walking, you're going to rule out other orthopedic issues. You're going to rule out things like Parkinson's disease that has a similar kind of walking, shuffling gait. So you really have to do a workup. And I always say the most important diagnosis is clinical. If those clinical pieces don't fit, it doesn't matter what the imaging looks like. And the way we diagnose it is, we started, about 20 years ago, an NPH clinic because interestingly, as a neurosurgeon, I saw a lot of people getting shunts that it was the wrong diagnosis. They were undergoing brain surgery because of these symptoms, and there really was no objective data. So what we started to do is do a very comprehensive, in our NPH clinic, patients come in, they get a baseline evaluation from our colleagues in physical therapy. We do a mini mental exam, a short neurologic memory and personality test, and then we remove fluid. We remove fluid from the back, and we take out quite a bit. And that's a key point that we've learned over the years. If you don't take the right amount out, you're not going to get the right result. And then an hour later, we repeat those exact testing. It's all done as an outpatient. And it is pretty close to black and white. And you see a remarkable recovery in patients with NPH that day. People come in literally in tears because they're, oh my God, I couldn't get up those steps for a year, 2 years. I thought this was it. And literally that day they're walking better. And we see it objectively. But what I generally do and what we do at GNI is we don't use that alone for a role for surgery. We use that in combination with sitting down about a week to 10 days post-procedure, post-removal of the fluid, and we talk to the patient and the family. If those things, and that's the most, because they're back in their own environment, they're back in their own home, and it's subtle things where, he or she, whoever the patient is, they would always be forgetting this type of thing. I would have to remind them. They were clear. Sometimes they talk about like a cloud lifting, just a clarity. And then, getting up and down stairs, not bumping into things, just being more nimble on their feet, the way they walk, the way they turn. They don't have to hold a wall. If that corroborates with the physical therapy testing with improvement, that patient is an excellent, excellent candidate for a shunt. And almost always they improve with a shunt.
Wow, that's really interesting. So I've heard in healthcare and certainly patients' worst nightmares, I guess, is like, let's rush to surgery, right? Let's just open up your brain. And what you do nowadays, I think the public, misconception is with neurosurgery, you don't have to remove someone's entire skull to perform a procedure. You can go in through, your groin or certain surgeries you don't even have to.
Minimally invasive.
Exactly, which is a lot of people don't know about.
Right.
They see in movies where it's over dramatized and people are removing somebody's skull. So that's very amazing that you can remove. So in the lower back, the spinal fluid, because I think a lot of people don't truly understand how spinal fluid, where it's located, and I do want to get into a little bit of the anatomy structure of where the ventricles are and how this anatomy of the spine and brain works.
Yeah, so we have a good image. I mean, if it, that shows this upper left hand corner is the ventricle, so that's that fluid filled space in the blue, and you can see it's this you can consider it almost
part
like
right
a balloon.
here.
Yep, the blue, exactly. And then if you go to the center, that's an actual CAT scan of a patient. The center of the thing, that's a CAT scan with somebody who has very large ventricles. You can see that black is that fluid-filled space. That's the ventricle. That's where the cerebral spinal fluid is produced and absorbed, and it freely circulates throughout the brain in these cavities and through opening into the spinal canal. So the pressure and the fluid in the back is the exact same as in the head. So that's where we can measure pressure through the back, and that pressure in the back is the same as in the brain. And we remove fluid from the back, which drains and kind of empties the cavity, so to speak, temporarily. So when we remove the fluid, you're not going to see those ventricles collapse, nor would you want to, because the brain will collapse in and you can get a hemorrhage in the brain. So we take off just enough where it's going to release the pressure on the fibers that are within the brain. If you go to that next slide over there, this is a tractography, a MRI, actual image of someone's white matter tracts in the brain. And you can see that that's where the ventricle is in that kind of center part. Those fibers in certain areas, as they get stretched, they cause the symptoms of normal pressure hydrocephalus, and namely cognitive, balance, and bladder issues. And when you take off the fluid, even though the ventricle size may not look any different on the CAT scan, you're reducing that pressure temporarily. It takes the pressure off those fibers, and that's when you see that dramatic improvement. Now, the problem, what I always remind patients with is, the question always is, which is a good question, well, why would you do brain surgery and put a shunt in if you just remove the fluid? Isn't the patient better? Well, the answer is no, because the body reproduces the cerebral spinal fluid. So what we remove gets replaced in about a week, sometimes shorter, but sometimes the effects will last weeks. But most patients, I say, expect in the 2 to 3 days after, you're going to see marked improvement, and then it's going to plateau, and then you're going to go right back to where you were as that fluid fills up again. But it's really important because it helps us prognostically as well. It tells us that you'll benefit from a shunt, because that's what a shunt will do permanently. And it also helps us rule out patients. That is just as important, that, if they don't get better with this, the likelihood that they're going to get better with a shunt is far less likely.
So if they don't get better with this, what do you typically, do you have to move towards something else and say we have to do some more testing to really kind of nail down what exactly the symptoms might be?
Yeah, and you had mentioned and alluded to earlier where the patients, want to avoid surgery. This is quite the opposite, where people, and I guarantee you there was already a rush of this, where people are seeing, a celebrity like Billy Joel, like, oh my God, I have those symptoms too. You want it to be something that's treatable. Right? You want a solution, which is totally understandable. But more times than not, when my patients undergo these lumbar punctures in this procedure and they don't get better, you'll see it where they'll almost try to, well, I think I'm a little bit better. And I feel like I'm better. But because they so desperately want a solution to their problems, which is, again, completely understandable, but you have to be responsible. And that's where this whole NPH clinic came about decades ago. Was too many people were getting shunts based on, well, yep, they have the symptoms, let's put a shunt in, let's see if it works or not. Surgery, particularly brain surgery, is not something you see if it works or not. It's not like medication, right? You start a medication, it doesn't work, you stop it. It's safe. Whereas surgery, there's no going back.
Right. Do you mind describing a little bit more just about, you mentioned the shunt. It's like a piece of, a very tiny piece, looks like a little plastic that you put. Where do you put it on the brain, or which part of the brain?
So we have another, a great picture if you want to show that does this. And there's a really interesting story to this. So, and it's a story I love. When I was doing my pediatric neurosurgery at CHOP, centuries ago, that was a center where we do lots and lots of shunts. Most pediatric hospitals, and CHOP's one of the best hospitals in the country, if not the world. So people would come from all over for shunts, and we kind of always took for granted. And I remember, the story of how the shunt was invented. It wasn't a surgeon, it wasn't a doctor, it was an engineer in Philadelphia in the 50s or 60s, whose daughter had hydrocephalus. She was born with it. And at that time, it was a lethal condition. We didn't have the shunt technology developed. We put external drains, they would get infected. We tried all these tunneling techniques. And her father was an engineer. And he said, there's got to be a way. This is engineering, it's physics. And it clearly is. He developed the first shunt for his daughter, which was the first internalized with a valve mechanism that opened and closed based on pressure. Now we have adjustable, programmable shunts where with a magnet we can change how much it drains. We're doing things like the Invisi shunt, where there's normally this big valve that sticks out. We can implant them deep now. As you know, we did one of the first in the country. There's lots of technology, but at the end of it, it's the same concept. You're putting a tube into that fluid-filled cavity in the center of the brain. It's being tunneled under the skin, over the clavicle. It's all under the skin. And we put it not into the stomach, but into the abdominal space, the peritoneum. And the reason we choose that is that absorbs fluid very well. So it constantly, as this fluid's drained, the body just absorbs it, the peritoneal lining. And then there's a little shunt. And if you see the drawing here, right there.
So here,
exactly.
This is the shunt right there.
So that's this one in particular is called Strata. There's many on the market. And what this does is that valve, there's a little bulb on it so that you can push it and it depresses to make sure you can see it refilling, that it works. You can put a needle in there to pulse fluid out. And again, this is under the skin. And when the pressure goes to a certain point, it'll open up and start draining fluid. And once it gets to that point, it stops so it doesn't overdrain. And sometimes we have to, especially with normal pressure hydrocephalus, sometimes it's a couple degrees. The normal pressure in the brain's anywhere between 5, 10. It can be lower, but anything over 20 is pathologic, and you start to usually get symptoms, and it's usually headaches, lethargy, things like that. But normal pressure hydrocephalus, by the name, it's a normal pressure. It's just more expansion of that cavity. So it's just draining that fluid just to get enough pressure off. So, but the pressure, we usually set it about 10 or 12. You don't want to overdrain, but those valves help regulate that fluid.
So do the ventricles ever return to normal size and you take the shunt out, or is this once it's in, typically for the rest of your life, you will have the shunt in place?
Yeah, it's a great question. So in younger patients that have hydrocephalus, the ventricles are a pretty good indicator, not always, but a pretty good indicator of they get big, they get small based on the patient's symptoms. Not normal pressure hydrocephalus. It's actually, it's not common where it changes that much because the ventricles are big to begin with. I can show you 2 CAT scans, two, same sex, same age, same everything. One has NPH symptoms, the other doesn't. The CAT scans are identical. Those ventricles, as we get older, our brain softens and shrinks. And so that fluid-filled cavity starts to expand into the soft space.
Yeah, it's really interesting as well that, engineers, the body almost kind of is like a machine where you're able to kind of pinpoint and, that you guys not work hand in hand with engineer, but there's a crossover between, medical devices and management of that. And then, you guys, especially at GNI, are able to work sometimes with people and help design things and come up with solutions, like you said, with the Invisi shunt, where cosmetically people can, the ultimate goal is to have them return back to their normal life.
Absolutely. And I think we've gotten away from that. Our philosophy is very much, we can't do anything without our partners in industry, technology, even engineers that may not have anything to do in the medical world. All those people have to come together. I mean, if you look at any of the major advances in the last 20, 30 years, every one of them has been a combination of working with people outside the traditional medical field. And I think when we shut ourselves off from that, we're really limiting ourselves.
No, I agree. And we've covered a lot of the science here, but just to shift back to, Billy Joel and fans of his and, everybody, I guess, around the world is wanting to know, what does he need a shunt, or what is, obviously you haven't seen the images, et cetera, but what can people expect? He had to cancel his tours, and people just want to know what's next.
Yeah. So, I mean, as you can imagine, we've been getting blown up with people from all over, actually, including patients who've had the surgery and, kind of comment on it. First and foremost is the right diagnosis. I'm sure he has excellent physicians and a medical team, but the diagnosis has to be correct. And I'm sure, again, I don't know anything about his care. I haven't spoken to anyone who is taking care of him. But my guess is he's going through a similar process of having some fluid removed to see, based on his symptoms improving or not. And if in fact he does have normal pressure hydrocephalus, the treatment, he would be undergoing a ventriculoperitoneal shunt. Mr. Joel, if you're listening, we're happy to talk to you about an Envisi shunt. And I say that kidding because he is bald, and what becomes very visible for people, whether you have hair or not, is this big valve that basically protrudes out of the skull. And that people will know, I'm sure he will, as he has done already, which he's helped millions of people by sharing his story. So it can help other people that may have these symptoms and be like, wow, I never even heard of NPH and I have those symptoms. But I'm sure he'll share if he does have surgery, but if he doesn't, you'll know because there'll be a valve there.
Yeah, I think what you mentioned as well with physical therapy, with GNI, you guys are, uniquely in a position where you kind of have everything under one roof, right? You don't have to send to different networks and people are going all over the place. And you guys, you especially are an expert in treating this condition. And like you said, the diagnosis, you've seen this, you know what to look for, you know what not to look for, and to rush to surgery, is not always the best option for people.
No, absolutely. And, we do have a multidisciplinary team, movement disorder, cognitive, and our neuropsychology team, Dr. Lester, who we did a podcast with. Many times, as you mentioned, if patients aren't really convincing that they got better on those treatments, the lumbar puncture, we will start doing a full battery of those types of workups to rule other things out and see what else this could be to help the patient. But it does take a team for sure. To be honest with you, and not to sound glib, I mean, the surgery is the easiest part. I mean, this is yes, it's brain surgery, and yes, there are risks to it, and I don't want to downplay that by any means. But in the grand scheme of what we do as neurosurgeons, it's one of the more routine procedures. So it's not really about the surgery. It's really about the right diagnosis and making sure that you understand this disease.
Well, yeah, it'll be really interesting to, keep track of this story and see with Billy Joel on what the official, diagnosis and everything else that comes out in the news. But for people that might have more questions about normal pressure hydrocephalus, or if they want to learn more about that at GNI, how could they find out more information about that?
Yeah, as always, I mean, we're, GNI.org on the internet. You can go to our website and get a full description of the doctors and NPH in general and what we do. We also have a second opinion site where we can, if somebody has a question and they want to send films in, we can look at it and go from there. But yeah, we treat this nationally. We have on our second opinion site, we get international consults as well. So we do quite a bit of this. And, really the goal is to be honest with you, and I think most neurosurgeons would say, I feel better when I've ruled something out almost than ruling it in and doing a surgery. The worst thing that you can do as a surgeon is to do a surgery and then after realize this probably was not the right diagnosis or the right thing to do with the patient for the patient, with the best intentions. It's just really being thorough.
Absolutely. Well, is there anything that we didn't touch on that you wanted to cover about NPH or Billy Joel's story, or is that pretty much?
No, I think as you said, let's stay tuned. I hope this is NPH because the symptoms, he should do well if this is the correct diagnosis, which I would assume it is. And again, for anybody listening, if there's any questions, or you're not sure, reach out to your doctor, reach out to your physician, reach out to your doctor, and be persistent.
Well, that's great. And yeah, as always, if there's any additional comments, please leave them down below, and make sure to like the video and subscribe to our channel. We have a ton of new content coming out with doctors like Dr. Vez and other talented members of the team coming out in the future. So thank you so much, Dr. Vez, for stopping by, and we'll see you guys in the next episode.
Thank you, Alec.